Yes.
Okay. Thank you for committee and everyone who play. Also, that I could be at this conference. I'm very proud to be here. On this question, I will present a review of baclofen as a therapy for central hyperthermia. We will explain what central hyperthermia is, what the pathophysiology is, and how baclofen can be used as hyperthermia central therapy. The background to writing this review is my experience with a fountain uh, their biological mechanism and response to therapy are different. Thus, their distinction is important. Pyrexia, also referred to as a fever, is an adaptive response to a physiologic stress that is tightly regulated through endogenous, pyrogens, and antipyretic pathway, and is associated with increase in the hypothalamic set point. As such, the elevated body temperature with pyrexia respond to pharmacologic antipyretic therapy, such as anti-acetaminophen. On the contrary, the elevated body temperature that occurs in hyperthermia, increase in body temperature is not associated with increased hypothalamic set point. This elevated temperature is therefore not responsive to pharmacology antipyretic therapy. Thus, central hypothermia and elevated body temperature caused due to impairment of thermoregulatory pathway in the brain respond poorly to antipyretic and antibiotic. Central hypothermia associated with high morbidity and mortality. Sung et al. Report this that elevated temperature over 39 degrees Celsius with patient stroke is correlated with high risk of death. Criteria to diagnose central hypothermia. Central hypothermia remains a diagnosis of occlusion. Hypothermia is detrimental to already injured brain, and the duration of fever is associated with poor outcome and recovery. Like mortality rate of 80% has been described in patients with intracerebral hemorrhage who develop central fever. Most fever in stroke is associated with infection. However, fever without documented infection, in example, central fever was determined in 33% of stroke patients in a prospective study. Thus, early identification of central fever is critical as it affects the treatment strategy. But the exact pathophysiological mechanism underlying central fever remain unknown. Hypothalamus coordinates several physiological mechanisms involved in regulation. And then pathophysiology change during malignant hyperthermic crisis. During contraction coupling, acetylcholine evoke an action potential at the neuromuscular end plate. This action potential is propagated to transverse tubulus, causing displacement of the change at the dipyridamine receptor. A conformation on conformational change at the voltage gate dihydropyridine receptor is directly transmitted to the ryanodine receptor subtype 1 at the sarcoplasmic reticulum, which responds by opening RYR1 receptor, a large ion channel, facilitate release of calcium to cytosol, leading to muscle contraction by inhibiting crosslink of myofilament. Active reuptake of calcium into sarcoplasmic reticulum via an adenosine triphosphate dependent calcium pump terminates the muscle contraction. In malignant hyperthermic crisis, the triggering agents induce prolonged opening of functional ryanodine receptor, resulting in uncontrolled release of calcium from the sarcoplasmic reticulum and ongoing muscle contraction as rigidity. Additionally, constant activation of aerobic and anaerobic metabolism results in increased oxygen consumption, leading to hypoxia, progressive lactate acidosis, excessive production of carbon dioxide, and increased body temperature. Calcium reuptake into the sarcoplasmic reticulum and sustained muscle contraction consumption of amount adenosine triphosphate. Depletion of cellular adenosine triphosphate stored leads to protected muscular rigidity and finally to rhabdomyolysis with background of membrane integrity results in a release of the content of cell. Few of the harmful effects of hyperthermia on the brain observed in many experimental models, it will seem obvious that the treatment aimed at reduce fever should be initiated in all patients with central hyperthermia, as well as hyperthermia induced by other causes. Unfortunately, there are no large randomized control and cold exacerbate and organs damage. The following are some agents that have been reported to be successful in improving central hyperthermia. Morphine, Central fiber remission has been reported in patients following traumatic brain injury. Chlorpromazine, when conventional therapy fails, sometimes chlorpromazine is tried and success rate varies. Chlorpromazine produces antibiotic action due to its ability to improve thermoregulatory reliability. Baclofen has been reported to be successful in treating long-term central hyperthermia in patients with basilar arterial occlusion leading to brainstem infarction. Bromocriptine is study report to successful use of bromocriptine in central fever. Growth therapy hormone, successful treatment of central fever with growth hormone therapy has been reported with a mechanism related to improve sweet production. The role of baclofen in the management of central hyperthermia. The use of baclofen that has been approved by FDA is to treat muscle spasticity. But besides that, baclofen also has several of label use. Baclofen is a beta subunit agonist of gamma aminobutyric acid in mono and polysynaptic neurons at spinal cord and brain level. Baclofen may be a treatment option in patients with central neurogenic hyperthermia. Baclofen that acts on nucleus and inhibit brown adipose tissue so that core body temperature can be lowered. The commonly used dose of baclofen is 30 and until 60 milligram days. And then organic control of the thermoregulatory system. In a normal physiology condition, the worm activate preoptic area in hypothalamus to suppress brown adipose tissue. Whereas cooling release this inhibition and activate brown adipose tissue. In the patient with an infarct involving bilateral pontine structure, the inhibitory signal from the inhibitory center is eliminated and brown adipose tissue is activated, which in turn increase the temperature, body temperature. Baclofen function as GABA acting directly on the rhabdoid nuclei to suppress activity of brain adipose tissue, in turn suppress the body temperature. Baclofen toxicity should be considered in the setting of hypotonia, and flaccid paralysis, while spasticity and hyperplasia are more commonly encountered with baclofen withdrawal. Baclofen toxicity can be life-threatening with hemodynamic stability, cardiac arrhythmia, and respiratory failure, often requiring admission to ICU. It is a clinical science and symptoms, baclofen toxicity and withdrawal. The difference in a system general, psychiatry, neurological, cardiovascular, respiratory, gastrointestinal, and musculoskeletal. Is the difference of baclofen toxicity and baclofen withdrawal. Contraindication. Baclofen is contraindicated in patients with hypersensitivity to baclofen or any of its components in the formulation. Baclofen should be used with caution in patients with impaired renal function. A dose reduction may be required. Limited data indicate that baclofen has no adverse effects in nursing infants or low levels of the drugs in breast milk. However, newborn should be monitored or for sign of sedation. The pregnancy category of baclofen is C. Baclofen is only given to pregnant women if the benefit outweigh the potential risk of to the fetus. Monitoring administration of baclofen with other central nervous system depression requires close supervision. Patients with epilepsy should have periodic monitoring due to deterioration of seizure control while receiving baclofen. As conclusion, central hyperthermia is still a diagnosis of occlusion. So, so that tracing the source of fever must be done. There are no guidelines for the management of central hyperthermia to date, but several agents, including baclofen, have been reported to improve condition. Baclofen can lower core body temperature with its mechanism of action as a GABA agonist acting on the rapid nuclei and inhibiting broad adipose tissue. The use of central nervous system depression further study are still needed regarding the efficacy and safety profile of baclofen as an option for central hyperthermia therapy. Further control trials with adequate sample size are recommended to evaluate and standardize the use of baclofen and other sex novel drugs in the management of central hyperthermia. Thank you.
Multiple sclerosis rehabilitation is a multidimensional process due to the nature of disease. Today, my topic is effects of sensory intervention in multiple sclerosis people. Uh, Multiple sclerosis is an autoimmune and neurodegenerative disease with wide range of symptoms, including visual impairment, muscle weakness and pain. One of the most common and annoying symptoms of disease is fatigue. Fatigue has been reported in more than 50% to 92% of multiple sclerosis patients. Now we should ask that question: what is fatigue in MS? Fatigue is defined as the lack of mental or physical energy that perceived by suffers or affects a person's norms and desirable activities. I should mention here that multiple sclerosis patient can distinguish between physical fatigue and other physical symptoms such as weakness, as well as between mental type of fatigue and emotional and mental symptoms such as lack of concentration. Disease progression can lead to fatigue increase. Also, environmental factors can modulate that. For example, fatigue increase with experience of heat and decrease with cold. Why fatigue and fatigue management important for me as an occupational therapist? Because all kinds of activities in a person's daily life can be affected by fatigue. So, when a multiple sclerosis patient report fatigue, we should predicting a global limitation and restriction in all occupational areas. And for last question, what is cause of fatigue in multiple sclerosis? Electroencephalography studies has been shown that damage to sensory and motor patterns and to functional communication of nervous system can be the central cause of multiple sclerosis related fatigue. uh, Electroencephalography topographical studies has been shown that there is a decrease in the amount of excitability in the primary sensory area and an increase in the amount of excitability in the primary motor area. Therefore, it seems that By affecting these areas, sensory intervention can be effective, and this study conducted to investigate these effectiveness. Excuse me, because screen sharing, if any deficit or disruption in the voice, please tell me to know and come back to the presentation. Okay, if tell me any disruption, I can better manage the presentation. Thank you. For the methodological approach of our study, this study conducted based on Prisma to identify related studies. We searched Google Scholar, PubMed, Scopus, and Cochrane Library database for English language articles published between 1990 and 2020 with using the keywords multiple sclerosis, MS, fatigue, touch, proprioceptive, and vestibular. Touch, proprioceptive, and vestibular because of sensory dimensions of brain that is very important as a
Hello,
near senses.
hello, doctor. Could you please change your slide?
Okay,
And now it's okay. Thank you.
okay. Hopefully it's good. Two experts independently examined the studies in terms of compliance of the title or summary with the inclusion criteria. The inclusion criteria for this review were studies with sensory intervention as a main or secondary intervention in people with multiple sclerosis, considering the effect of fatigue as a main or secondary outcome. Only English language, as mentioned, were included. Uh, Data extraction from studies was performed using a standardized form of data extraction based on consort that standards for reporting trials to assessing quality of evidence of the studies included in this review was evaluated by the Downs and Black checklist. The checklist is a 32-point scale that was developed to assess the methodological quality of randomized controlled trials and non-randomized studies. For the result of this study, we found 94 studies in the search, and from the search, 21 were omitted due to duplication in the first stage, and then 57 studies were omitted based on the title, and another uh, 7 based on the study abstract. 9 studies were entered for full text screening, and online were submitted to a review of the entire text and had inclusion criteria and did not have exclusion criteria. Of the studies in this included in this systematic review, 8 are randomized controlled trials, and one is a pre-test, post-test study. The period of treatment in these studies included range from 5 days to 12 weeks and consisted of 5 to 60 sessions. The duration of sessions varied from 10 to 75 minutes. Only 3 articles two studies, and we have these of 17 to 80 people in 223 who received the research-related intervention, sensory and other exercising based intervention, and 134 in the control group or on the waiting list. I think I should say another important data on this work, that assessment of the use assessment that used in the studies included in the 9 studies article. 3 fatigue-related assessments were used to measure the severity and extent of the effect of fatigue. The fatigue severity scale FSS, modified fatigue impact scale MFIS, the fatigue impact scale FIS were used. We have 3 type of intervention performed in the article. 3 category we have. 4 studies related to exercise category. Among this type of interventions, sensory intervention exercise were the most used. Another study examined vestibular rehabilitation, and one study examined Frankel exercise. Exercise in these studies were designed to integrate multiple sensory inputs while evoking a postural equilibrium response. Some studies done varied. In one study, balance exercise were performed in various positions using biofeedback plates or on the floor and in the front of mirror to providing visual feedback that is very important for physical rehabilitation based on the latent articles in this area. Another study used sensory intervention exercise in 3 levels of open eyes, closed eyes, and with visual conflict to create wrong input, and also on 2 levels of floor and foam mat. As you know, the reason of this labeling is functional connectioning of balance system with a visual system that is structured developmentally. All vestibular rehabilitation studies had 2 training sections. One section for position exercising and the other one for eye movement. And in one study, Frankel exercise used that exercise done in the lying down, sitting, and standing. A second category of intervention was robotic one. The robotic was used as gait aid in 2 studies with sensory input, and the third category was total vibration only without any other uh, sensory or exercise or any interventions. Okay, what's the effectiveness of these interventions? Exercise-based intervention, as mentioned, sensory integration exercise, vestibular intervention, that is very important, and Frankel exercise. In 9 studies, comparing two type of intervention based on walking robots with sensory motor exercising. One study showed very important to fatigue in measuring. In another study, results showed a significant reduction on FS. Okay, I think that
Welcome everyone to my today's presentation. In this presentation, we will go into a great detail on how hallucinations and delusions might indicate cognitive impairment in Alzheimer's disease. As we delve into this topic, we'll uncover the complexities surrounding these symptoms and the implications for patient care. Here is a brief review of Alzheimer's disease. So cognitive decline is the very hallmark of Alzheimer's disease, which is a neurological condition that progresses over time. It impairs thinking, memory, and behavior, ultimately making day-to-day functioning difficult. I have attached here a small video showing the brain atrophy in Alzheimer's. I would like to go into more detail of it. In Alzheimer's disease, atrophy refers to the progressive shrinking or loss of brain tissue, particularly in regions critical for memory, cognition, and other neurological functions. We can have a look at the bar graph here, which shows us the number of deaths from Alzheimer's in 2000 and the number of deaths from Alzheimer's in the year 2019. And we can see this has almost doubled in the last 20 years. Let us talk about the pathophysiology of Alzheimer's associations with delusions and hallucinations. The pathology of Alzheimer's disease, which is typified by tau protein tangles and beta amyloid plaques, can result in extensive neuronal loss and dysfunction, impacting the parts of the brain in charge of perception, higher cognitive abilities, and sensory processing. As you can see in this small diagram over here, it shows a healthy neuron and a neuron with tau protein tangles and beta amyloid plaques in the brain of an Alzheimer's disease patient. Now, tau protein is a microtubule associated protein that plays a very crucial role in stabilizing microtubules within neurons, thus aiding their structural integrity and transport of nutrients and cellular components. In patients with Alzheimer's disease, tau undergoes abnormal aggregate and hyperphosphorylation. Thus, it causes it to be detached from the microtubules and hence form tangles inside the neurons. Beta amyloid plaques. Beta amyloid is a peptide produced, as you can see here, which shows A beta plaques. So beta amyloid is a peptide produced through the cleavage of amyloid precursor protein in the brain. In Alzheimer's patients, beta amyloid peptides accumulate abnormally, forming insoluble plaques outside the neurons, which then interfere with neuronal communication. Pathophysiology of Alzheimer's association with delusions and hallucinations. Delusions, hallucinations, and cognitive impairment in Alzheimer's disease may also be caused by change in neural networks that link different parts of the brain and dysfunction in cortical subcortical circuits. Neurological circuits and cognitive processes may be further disrupted by the physiological distress, depression, anxiety, and social isolation that are frequently seen in Alzheimer's disease patients. Recognizing delusions and hallucinations in individuals with Alzheimer's disease or other forms of dementia is very crucial. Now, as we know, hallucinations are a perception that arises in the absence of an outside stimuli, while delusions are irreversible erogenous beliefs in the face of contradicting information. They both cause distress and difficulties with activities of daily living, which can arise from these both symptoms. And we can actually help and aid in recognizing these features by observing behavioral changes, listening to patient reports, considering context and patterns. Now, the types of hallucinations, auditory hallucinations. They are when a patient hears certain voices or sounds. Visual hallucinations, seeing people, objects, or shapes. I have put down a small video of a visual hallucination in context of what a patient feels like and what they see. Olfactory hallucinations, smelling odors not present. Tactile hallucinations, feeling sensations on the skin. Types of delusions. Paranoid delusions. Believing that others are actually plotting against oneself. Grandiose delusions. Exaggerated beliefs about one's abilities or status. Somatic delusions. Believing one has a physical illness despite evidence to the contrary. Now, prevalence of hallucinations and delusions. Studies indicate that delusions or hallucinations affect 25 to 40% of Alzheimer's disease patients. The severity of the condition rises prevalence. Underreporting is very frequent because of poor communication. Now, as you can see in this like comparison graph right here, so from this graph we can deduce that the visual hallucinations are more common in Alzheimer's disease than auditory or other types of hallucinations. Visual hallucinations may occur in up to 40% of individuals with Alzheimer's disease. Paranoid delusions are among the most common types of delusions in Alzheimer's disease. Other types of delusions, such as delusions of theft or infidelity, may also occur but are less prevalent. Individual factors such as the presence of other comorbidities such as Lewy body dementia or vascular dementia may influence the prevalence of hallucinations and delusions. Impact on cognitive abilities. Cognitive deficiencies are made worse by hallucinations and delusions. They impede executive function, memory, and concentration. Increased severity and frequency are associated with a quicker rate of cognitive deterioration. Mechanisms that underlie delusions and hallucinations. These symptoms emerge as a result of neurobiological processes. Neural networks, anatomic brain alterations, and dysregulation of dopamine are implicated. Other possible factors include negative effects from medications, social isolation, and sensory impairments. Dopaminergic dysregulation. The dopaminergic and cholinergic systems are out of balance. Dopaminergic antagonists help reduce symptoms, but they may impair the cognitive ability of the patient as well. Dopamine receptor targeting is one possible treatment approach. So what happens is the cholinergic system, which is primarily involved in attention, memory, and learning, is particularly affected. And concurrently, the dysregulation of dopaminergic system, which is involved in reward motivation and movement control, is also affected. So what we can do in future is something like dopamine receptor targeting. Structural brain changes. Studies on neuroimaging show that delusions and hallucinations are linked to structural changes in the brain, modifications to the cortical and subcortical areas related to perception and thought processes. Amyloid buildup and hippocampal shrinkage might be factors in symptomatology. Structural brain changes. The causes of hallucinations and delusions is disruption of brain networks. Anomalies pertaining to visual processing pathways, salience network, and default mode network, impaired reality monitoring, and sensory information integration. As you can see on the slide, so this is showing us the structural brain changes which occur in Alzheimer's disease, which involve progressive atrophy and neuronal loss in regions critical for memory, cognition, and other high-order functions. These changes reflect the underlying pathological processes of Alzheimer's disease and contribute to the cognitive decline and functional impairment observed in affected individuals. Predictive value in Alzheimer's progression. Longitudinal studies show that delusions and hallucinations occur before cognitive impairment. So they are the early markers of the severity of disease, and they indicate a relatively poor prognosis. The paths of cognitive decline are more steeper in patients exhibiting these symptoms. Cognitive decline trajectory. A quicker rate of cognitive loss is observed in Alzheimer's patients who exhibit hallucinations and delusions. Multiple cognitive domains such as memory, attention, and language are impaired. An increased chance of functional impairment and placement in a nursing home. Now, in this picture, you can see that, that here is an overview of cognitive impairment and dementia stages in Alzheimer's disease. The first one is called the preclinical stage. So in the preclinical stage, individuals do not exhibit noticeable symptoms of cognitive impairment, but underlying pathological changes, such as the accumulation of beta amyloid plaques and tau protein tangles, are already occurring in the brain. In mild cognitive impairment, that is a transitional stage between normal aging and dementia in Alzheimer's disease. And in this, memory impairment is typically the most common feature of mild cognitive impairment. As this progresses to early stage, which is also known as mild dementia, it is characterized by mild cognitive and functional impairment. In middle stage, that is called the moderate dementia. In this, memory deficits become more severe. In late stage, which is called severe dementia, the late stage of Alzheimer's disease is characterized by profound cognitive and functional decline. Clinical implications. In order to effectively treat Alzheimer's, hallucinations and delusions must be identified and treated. Screening instruments that help with symptom identification and quantification include the neuropsychiatric inventory, which is called NPI, and it's a very common tool which is being used today. A multidisciplinary strategy incorporating geriatrics, neurology, and psychiatry is essential for all-encompassing treatment. Pharmacological interventions. Antipsychotic drugs are frequently used to treat delusions and hallucinations. Atypical antipsychotics, such as quetiapine and risperidone, are recommended because they have a decreased chance of extrapyramidal adverse effects. It is important to remain vigilant for adverse effects, particularly sedation and metabolic syndrome. And we are mostly dealing with very elderly patients over here. Non-pharmacological interventions. The main goals of behavioral therapies are to improve coping mechanisms and alter environmental triggers. Cognitive distortions and false beliefs are the focus of CBTs. Psychoeducation enhances comprehension and coping for both patients and caregivers. Caregiver support. So the people who are actually caring, they also have a huge load of responsibility. So support from experts is needed for those who look after Alzheimer's disease patients who have delusions and hallucinations. Training on communication strategies and symptom management, support groups, and respite care reduce the strain and stress on caregivers. Future directions. Innovations in biomarkers might help in early intervention and diagnosis. Precision medicine techniques founded on unique neurobiological markers and symptom treatments, combining clinical, imaging, and genetic data to provide individualized care. So now functional MRI, for example, genetic testing can identify risk factors associated with Alzheimer's disease, such as the presence of certain genetic variations like the apolipoprotein E allele. Neuroimaging techniques can visualize structural changes in the brain, such as hippocampal atrophy or cortical thinning, which are indicative of disease progression. These data, along with clinical observations of cognitive decline and behavioral symptoms, inform the development of personalized care plans tailored to each patient's unique needs and circumstances. Advancements in neuroimaging. The neurological basis of delusions and hallucinations can be better understood thanks to high-resolution imaging methods. Studies using functional MRI clarify the network disruption that underlies symptomatology. Pharmacological therapies can be targeted via neurotransmitter systems and PET imaging. Neurocognitive rehabilitation. The goals of cognitive training programs are to enhance reality orientation and cognitive performance. Computerized cognitive exercise aim for improving executive function, memory, and attention. Advantages go beyond treating symptoms. They also improve general cognitive reserve. Virtual reality therapy. Patients can get desensitized to hallucinations by means of regulated stimulus exposure in virtual reality environments. Immersion experiences lessen discomfort and encourage reality testing, showing promise as an adjuvant therapy for the treatment of hallucinations. So this is the most latest technique which is being integrated with the latest technology that we have today. Now we have some of the case studies. So here's my first case study. A 75-year-old Asian woman suffering from Alzheimer's disease started having visual hallucinations. She got more anxious and afraid after reporting seeing visitors in her house. Her caregivers reassured her, but the hallucinations continued and became more intense with time. Decreases in executive function and memory were found via cognitive evaluation. There was a correlation between her hallucinations and her cognitive impairment getting worse, which made her more confused and disoriented. Antipsychotic medicine and behavioral therapies to reduce distress were part of the management. The next case study, an 80-year-old African American man suffering from Alzheimer's disease experienced paranoid delusions. He thought his neighbors were planning to hurt him and were spying on him. The patient continued to be persuaded that his ideas were true in spite of evidence to the contrary. His illusions had a serious effect on his relationships and day-to-day activities. Attention and problem-solving deficiencies were identified by a cognitive testing. Delusions made his cognitive deterioration worse and made him retreat from social interactions. This is my last case study. An elderly Hispanic woman, age 70, suffering from severe Alzheimer's disease, reported experiencing auditory hallucinations. She constantly heard insulting words on her or her name being called. She was distressed by these hallucinations, which also made her agitated and unstable emotionally. Cognitive tests revealed significant language and memory impairment. Her hallucinations were linked to a sharp drop in cognitive performance, which resulted in reliance and functional impairment. Management prioritized creating the best possible atmosphere for her and provide consoling care. Analysis of all the case studies so far. Delusions and hallucinations were always linked to cognitive impairment in every case study. These symptoms made pre-existing disabilities worse and made it harder to go about everyday tasks. The goal of management techniques was supportive care and symptom relief. Key takeaways. Delusions and hallucinations are not distinct symptoms of Alzheimer's disease. Rather, they are signs of underlying cognitive impairment. Comprehending how these symptoms interact with cognitive loss is essential to provide patients with an all-encompassing therapy. For the very best results, therapies that are specifically designed to address cognitive and psychological elements are required. In conclusion, I would like to say that delusions and hallucinations are important indicators of cognitive impairment in Alzheimer's patients. To maximize patient care, these symptoms must be identified and managed. In order to improve our comprehension and management of these integrate occurrences, more study is required in this field. These are my references.
Much for your patience, and thank you very much for organizers of the Congress for the invitation and the opportunity to speak. Comprehensive CBT implies both the use of psychological therapy in conjunction with medication and use of the entire modern arsenal of diagnostics and the technical tools of CBT. In this and the following slide, you can see typical pharmacological medication, psychopharmacological medication used to treat anxiety disorders. They can be used to reduce the severity of symptoms both before the start of psychotherapy and in conjunctions with ongoing psychotherapy. The efficacy of cognitive behavioral therapy for anxiety disorder is well established, at least in terms of pre and post-treatment reduction of the anxiety severity. In this slide, you can see highlights research data that indicates the low recurrency rate after completion of psychopharmacotherapy for both depression and anxiety disorders. Sorry. The see the CBT and neuroscience data, efficacy of cognitive behavioral psychotherapy, well established, and you can see the see that neuroscience good base to explore the efficacy of cognitive behavioral therapy, but what the theoretical basis of CBT? It's based on the cognitive model proposed by Aaron Beck in early 60s of the 20th centuries. The expanded cognitive model has become more holistic, emphasizing the connections of each of elements of their mutual influence. In practice, we see this through the example of supportive cycles, including supportive cycles of anxiety disorders, where both our own psychological reaction and emotional background influence information processing, and due to, for example, catastrophizing in thinking and avoidant behavior, which support unrealistic expectation, beliefs, and the requirement that consolidate the viscous cycle of anxiety disorder. Simplifying it, we can say that excessive anxiety and anxiety disorders are the result of overestimation of danger and underestimation of resources. Therefore, the key manifestation of dysfunctional anxiety will be following sign, which you can see on this slide. All term of closely interrelated with the specific of the thinking of anxious patient. We can trace a number of typical cognitive distortion. We leave the mark of perception, attentional selection, and specific information processing, specific features of thinking and conclusion, and associated excessive emotional, psychological, and behavioral reaction. Such features of thinking and the specific of the automatic thoughts named by Beck are not accidental. They are connected with the entire structure of the human psyche and described in the so-called cognitive conceptualization. You can see in this slide the problem-oriented cognitive conceptualization proposed by Juliet Beck in 1993. Cognitive behavioral therapists fill in this conceptualization using relevant examples of excessive patient anxiety, suggestive that they describe the most striking examples when they occur according to the structure of the cognitive model. That situation became triggers that key thoughts influence for the formation of anxiety, fear, or panic, that bodily discomfort, for example, palpitations, pressure rise, muscle tensions, fever, and so on. The patient felt in his body and how they began to behave in connection in these emotions and bodily sensation. First slide. After studying several such examples, the therapist helps the patient to see the recurring key automatic thoughts, and they contribute most to the formation of excessive anxiety and the subsequent bodily and behavioral reaction. And already using analysis of these recurring key thoughts, the therapist helps the patient to realize the typical compensatory behavioral strategy, such as avoidance and hypercontrol, which form the basis, so-called safety behavior. It also helps to understand the basic set of intermediate beliefs, the rules of which the patient relieves his relationship and conditional assumption in form of key expectation. And also explore the dysfunctional self-model or self-concept, which is served by dysfunctional intermediate beliefs. I'm weak, helpless, and the world is full of threats and dangers, so I must foresee and control my condition, and where I cannot do this, I must avoid such situation. But not only problem orientation. In 2022, in the new edition of book of Judith Beck, book Cognitive Behavior Therapy, you can see the cover of this book in the slide. Cognitive Behavior Therapy Basic and Beyond. Judith Beck show the new model, another model of cognitive conceptualization that suggested considering the strength of the person using inappropriate conceptualization. Now, cognitive behavior therapists rely on holistic model in diagnosis, where problem-oriented approach explore the pathogenesis of disorders and problems and the conceptualization of strengths in focus of resources and sanogenesis or salutogenesis. Both conceptualization become the basis for a therapy plan, which more structured information for the formation of the therapy target and its stages. Many methods and techniques in CBT, used in CBT, a number of techniques aimed at relaxation and mindfulness contribute to the immediate reduction of anxiety. However, exposure or exposure therapy methods are considered to be the most commonly used and most effective for anxiety therapy. Psychological treatment, what was developed, it helped to people confront their fears. When people are fearful in something, they tend to avoid the feared objects, activities, or situation. Also, this avoidance might help reduce feeling of fear in the short term. Over the long term, it can make the fear become even worse. In this form of therapy, psychologists create a safe environment which to expose individuals to the things they fear and avoid. The exposure to the feared object, activities, and situation in a safe environment helps reduce fear and decrease avoidance. Exposure therapy has been scientifically demonstrated to be helpful treatment for component for range of problems, including phobias, panic disorder, social anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, and general anxiety also. There are some types of exposure. First of all, in vivo exposure, directly facing and feared object, situational activity in real life. For example, someone with fear of spider might be instructed to hold the spider, or someone with social anxiety might be instructed to give speech in front of the audience. But in difficulties with vivo exposure, we can use imaginal exposure, vividly imagining for the feared object, situational activity. For example, someone with post-traumatic stress disorder might be asked to recall and describe his or her traumatic experience in order to reduce feelings of fear. In some cases, we can use virtual reality exposure. Someone with a fear of flying might take a virtual flight in the therapist office using equipment that provide the sights, sound, and smell of an airplane. And the same story with spider phobia and other. Interoceptive exposure, deliberately bringing on physical sensation that are harmless yet feared. For example, someone with panic disorder might be instructed to run in place in order to make his or her heart speed up, and therefore learn that this sensation is not dangerous. You can see other methods: graduate exposure, floating, systematic sensitization, and we can use them in other cases. For example, particular conceptualization of general anxiety disorder, it becomes clear which therapy targets and which techniques will be used. Awareness, cognitive structure, evaluation of beliefs about worry time, and view exposure to uncertainty, imaginal and emotional exposure, relaxation training, and mindfulness techniques. But the end of my presentation, I want to say some words about new conceptualization, what based on needs, and it's a new opportunities that needs-oriented conceptualization provides. It's based on well-known biopsychological model for Josh Engel. Needs are the construct what can be used to the better understand both of the genesis in a person, dysfunctional and functional beliefs, and the study of their actual needs. Unsatisfies or frustration needs contribute to the formation of dysfunctional beliefs, and in turn, satisfies needs contribute to functional beliefs. Needs-based conceptualization and to add to the traditional methods of conceptualization, a wider model of the genesis of core beliefs and schemas. This model is built case on client needs and with the use of the docentral biopsychosocial model, what divides all the needs into 3 domains. This model always consider the genesis as well as development of dysfunctional beliefs and thoughts of every level of complex relationship with unmet, frustrated needs and the sensitive period of development, relevant childhood data, and the whole life, relevant lifetime data. It also follows to use more precise data collection according to the context of different systems level. This includes super system that include open personal system, a client family as a system, micro society and macro society system, collective ethics group, country, population, human civilization. Thank you very much for your attention. And in conclusion, I want to say that cognitive behavioral therapies grow and have a good neuroscience base, but each decades have new models, and we hope that new conceptualization models, Judith Beck and these models can help practitioners have more good practice with anxiety disorders.
I'm gonna present. This is my dissertation research that I had done. So it's about neuropsychiatric morbidity among inpatients with recent mild and moderate traumatic brain injury, a cross-sectional hospital-based observation study. Yeah. So traumatic brain injury is a major public health problem, resulting in significant morbidity, mortality, and great loss in productivity of an individual. Like globally, it is estimated that like nearly 10 million people sustain severe brain injury, leading to hospitalization and healthcare cost utilization. Especially in India, nearly 1 million persons they get injured. Like 2 lakh people die, and nearly 1 million require rehabilitation services every year in India. In the city of Bangalore, Karnataka, India, where I come from, nearly we can see like around 1,000 die every year as per the statistics. So what is the definition of
traumatic brain injury. Like, so it's an alteration in brain function, or there is an evidence of brain pathology caused by an external force. Now, what is this external force? It's about objects penetrating the brain, the head striking or being struck by an object, acceleration or deceleration of brain, or exposure to forces associated with blasts. Right? The signs of alteration in brain functions can be conceptualized into neuropsychiatry issues, like which we are going to talk about in subsequent slides. So neuropsychiatric sequelae predominantly, in the literature, has been classified into acute versus chronic, or it has been classified in terms of cognitive and behavioral symptomatology. Behavioral, if you talk about behavioral issues, then it is post-traumatic agitation, aggression, irritability, affective symptoms like anxiety, depression, manic-like features, insomnia, personality changes have been reported. And in terms of cognitive deficits, like the more like the severe the head injury, the more the persistent cognitive symptoms have been reported. 30 to 80% of patients with mild to moderate traumatic brain injury experience symptoms at least for the period of 3 months, although it's said that it resolves quickly, and almost 80 to 90% people they recover by 6 months of duration. About 65% of patients with moderate to severe traumatic brain injury report long-term problems with cognitive functions like even it could be beyond 1 year also. And sometimes there could be residual deficits that could persist. So thereby what is happening is it causes significant dysfunction in daily living. And I say dysfunction in terms of work life, social life, and personal life, right? So depending upon the localization, lateralization of the injury, the extent of the injury, medical and psychiatric comorbidities, and pre-psychosocial or post-psychosocial factors, you can expect the dysfunction to either magnify and get extrapolated in day-to-day life. And usually the frontal subcortical circuits have been postulated to cause significant dysfunction, as it causes attention difficulties and concentration difficulties. So the lesions predominantly affecting the frontal and temporal lobes have been postulated to cause significant dysfunction. The neuropsychiatric sequelae of head injury may frequently be undertreated with psychiatric and psychological intervention, and do not usually receive an adequate follow-up. There are many studies that have investigated symptoms occurring several months or later after traumatic brain injury. Few studies have focused on symptoms within 1 month post-injury. It is therefore essential to study both cross-sectional and longitudinal aspects of neuropsychiatric morbidity systematically and understand these sequelae. So what we did was, so this led to this study. So the aim is to study the prevalence and pattern of neuropsychiatric morbidity among inpatients admitted with recent mild and moderate traumatic brain injury. Objectives were to assess systematically the behavioral and cognitive symptoms among inpatients with recent mild and moderate traumatic brain injury, to understand clinical and brain imaging findings in these patients. The methodology, the source of data, it is a cross-section study. The study site, the study was conducted in liaison with Department of Neurosurgery at St. John's Medical College and Hospital in Bangalore, which is a 1,200-bedded tertiary hospital. Study participants were inpatients under neurosurgery department with recent mild and moderate traumatic injury and who were stable and ready for discharge from hospital. So sample size, the sample size was calculated based on the study by Kim et al., keeping 20% relative precision for the estimate and 95% confidence interval. Purposive sampling of convenience was used to select 61 sample size meeting the inclusion criteria of the study. The study was conducted between January 2015 to June 2016. It was approved by Dissertation Review Committee and Ethical Review Board Committee of St. John's Medical College Hospital. So the inclusion criteria, in patients with recent, when I say recent, it is usually less than or equal to 7 days of hospital stay. Mild and moderate traumatic brain injury as classified using Glasgow Coma Scale. GCS more than 6 hours were recorded, right? Were taken into consideration. So mild head injury, GCS of 13 to 15, moderate head injury, GCS 9 to 12. Age group 18 to 16 years. Patients should be clinically stable and oriented to time, place, and person. ICD-10 code or S06 was taken into consideration. Patient should provide informed consent, or it could be from the family members as well. Patients who can speak, read, and understand English, Kannada, Hindi, and Telugu were taken into the consideration. If the patient, from the caregivers, at least who lived with the patient during last 1 year, were taken into consideration. So exclusion criteria: prior traumatic brain injury using OHI or traumatic brain injury identification method, sensory motor or language deficits that would impair interviewing and psychological assessment, delirium, dementia, stroke, seizure disorder, right, mental retardation, and patients who were discharged against medical advice were the exclusion criteria. So basically, head injuries where there is involvement of any nerve, if there is a penetrating wound, open laceration, like crush injury, they were all under exclusion criteria. So the study flow is as follows. So based on the inclusion and exclusion criteria, study participants were recruited. Study relevant socio-demographic data, clinical data, and brain imaging findings were recorded in a specific format defined for the study. MiniPlus was used to generate cross-sectional and lifetime psychiatric diagnosis. Subsequently, neuropsychiatry inventory clinician was used, and hospital anxiety depression scale was administered to assess behavioral symptoms. Addenbrooke cognitive examination was administered to assess cognitive symptoms. So statistical analysis, it was data distributions were analyzed for normality and analyzed using descripting parametrics statistics methods. Continuous variables were presented as mean or median and interquartile range, right? And statistical significance was assumed to be less than 0.05, and association was usually used with the help of chi-square test and t-test depending upon the statistical method used, and it was analyzed using SPSS version 20.0. So the results and analysis. So the clinical profile of the study participants were as follows: like 55% were predominantly mild head injury cases, N is equal to 33, and moderate head injury were of 45%, N is equal to 28. So coming to social demographic data, so predominantly the age group that we had seen was between 18 to 35. Male were predominant. Most of them were married, right? Majority of the study participants had at least high school education, and a few and subsequently people had education up to pre-university and graduation. Most of the people were semi-skilled and to semi-skilled in terms of occupation, and they belong to upper middle and lower middle socioeconomic status, and we had a mix of rural and urban population. So in this slide, we are seeing a pie chart of more or less of neuropsychiatric symptoms from mild and moderate head injury. What we can see is definitely that in moderate head injury, you can see the irritability component, anxiety component, dysphoria, agitation. So it is more when compared to mild head injury. This we'll be able to see in a much better in a bar diagram, which I'll explain subsequently. So what we can see is anxiety component, right? So we'll just come to this. Yeah. So in this, the green symbol shows the frequency percentage for moderate head injury, and the yellow component is frequency for mild head injury. So what we can clearly see is that especially dysphoria, right? Agitation, irritability, anxiety, aggression. So they were predominant in moderate head injury, right? Coupled with the sleep disturbances. Whereas in mild head injury, their component is also there, but it is less when compared to moderate head injury. And in mild head injury, what we can also see is that sleep difficulty is more, almost equivalent to anxiety component, right? So now what we did was, like, we also used HADS scale to check because HADS is known to pick up good anxiety and depressive symptoms, at least in medical comorbidity, people who have been hospitalized. So now when we cross-check with anxiety and depression, so we could get a significant correlation, right? So the dysphoria component of neuropsychiatry inventory, right? So correlated pretty well with depression in HADS, with a clinical significance, right? And similarly for anxiety component in neuropsychiatric inventory clinician version to anxiety in HADS also showed statistical significance. Now, next, what we did was, with the help of Addenbrook cognitive examination, we checked the individual cognitive domain and we compared with mild and moderate head injury. What we could see was that the overall cognitive domain score for Addenbrook was more was very less when compared to moderate head injury and with mild head injury. So the areas which predominantly we could see was like in terms of attention, right? So the mean scores for attention, visual spatial memory, right? Verbal fluency, language. So we could see that in almost all cognitive domain. So the moderate head injury had a lesser score. The lesion distribution was as follows. We had a decent mix of involvement of both the hemispheres. However, right hemisphere was predominant. Almost equal, like, okay. And the frontal and the temporal lobes involvement was more when compared to parietal. And we had more of a subarachnoid hemorrhage when compared to subdural hemorrhage. So then we checked whether the cognitive domain, do they have any difference with respect to frontal and temporal lobe, because they constituted majority of the involvement of the lobes in our study. But we couldn't as such get any statistical significance in terms of attention, visual, spatial, memory. But what we could notice is memory was more affected in temporal lobe people, right? So the mean scores was less when compared to frontal lobe involvement. But again, statistical significance was not reached. Then we checked for various neuropsychiatric symptoms and to see whether, like, if the frontal lobe is involved, whether we get any more of aggression, more of agitation, or any in terms of like any judgment impairment kind of a thing. But as such, we couldn't get any statistical significance for any of the neuropsychiatric inventory psychiatric symptoms. Right. So let's see now the discussion part. Right. So the neuropsychiatric are frequently observed post-traumatic brain injury. So the earliest review of literature traces back to the case of Phineas Cage, right, where his rod had gone through his frontal lobe and there was significant behavioral issues. So earliest Indian studies also dates back to around 1974 and 75, work done by Pandey, VK. Right. We have even Keshavan, Dr. Keshavan, and Sebastian et al. And also they had contributed significant to neuropsychiatric studies in traumatic brain injury. So most of the people like especially Chatterjee and Keshwar et al. Had got a mix of cognitive and psychotic components. Sebastian et al. Had a mix, fairly mix of cognitive and neuropsychiatric symptoms. But most of the studies, what we have, they were predominantly looked into like 3 months, 6 months, 1 year down the line neuropsychiatric symptoms. There were very few studies that actually checked upon like within 1 month. Especially in our case, it is like 7 days, right? So that was the dearth in the literature. So yeah, the incidence of head injury usually peaks around the age of 15 to 25 and thereafter falling off and only to rise again in later years. So like in person under 45 years of age, traumatic brain injury is a leading cause of death and disability with an overall mortality rate of 25 per 1 lakh. So the mean age of the sample in our study is around 33, right? Men constituted around 93.4% of the sample, like 59% of the sample belong to the age group of 18 to 35, which you can say that the majority of the sample size goes hand in hand with the statistics. And also, like most of the earlier studies have also, in them also they have got that men prevalence or the incidence is more when compared to women. At least in India, probably men usually were like they have more of cab driving, drivers by occupation, manual labor. They were like men frequencies are more, although it's changing, but that is how it was. Maybe that could be the reason. In our sample size, 55% were mild head injury and 45% were moderate head injury. 73% right had traumatic brain injury due to road traffic accident, and 13% had traumatic brain injury due to fall from height. And people who had road traffic accident, they were all predominantly moderate head injury. And people who had fall from height were having mild head injury, right? Especially in our found in a study by Gurra, where he had got that like road traffic accident constituted around 59% of traumatic brain injury in his study. When you come to neurology post-traumatic brain injury, the frequency is around 11 to 70%, and depression around 25 to 50%. Right, and usually it's been said that depressive symptoms go hand in hand or coexist with anxiety. But the caveat is that majority of these figures, they are all usually from 3 months, 6 months, and 1 year post-traumatic brain injury prevalence rates. Right, so the anxiety in our case, in our study, it was like totally it was around 39%. Like but in exclusive in mild head injury, it was 46%. I mean, compared to moderate, it was 54. Depression, like dysphoria presentation, mild head injury, it is 22%, and moderate as 88%. So you can see that as the head injury is increasing, it is more of dysphoric presentation increases coupled with anxiety. Right, and as I said before, it showed a good statistical significance with Spearman correlation with HADS also. Seal et al. Had reported that depression early part of head injury may present with irritability, anger, aggression than by sadness and tearfulness. Right. So even Rappaport et al. Had reported that 15% of the patients had major depressive disorder in 1.5 months and 28% within 6 months. So 15%. Here we have got 22% in mild. Like overall, it is 15%. So it goes hand in hand, almost similar to the previous study. Next is sleep disturbance. So, and it's been reported 30 to 70% of the patient usually have sleep-wake disturbances. So in our sample, it went up to around 39%. So predominantly patient had delayed sleep onset, insomnia. Hypersomnia was prevalent in 2-3 cases only. Right, specific complaints included like snoring or nightmares, poor sleep efficiency, probably also coupled with pain. Right, so despite good adequate pain management, also people used to have difficulty and in sleeping, and sometimes in middle night awakening, and causing poor sleep quality and decreasing further threshold of pain. Irritability, aggression, and agitation. Irritability, aggression, and agitation is more with increase. It's more with increase in the severity of head injury, right? And its range is around 11 to 34%. In our study population, 9.8%, almost 10% to 15% had aggression and agitation respectively. Again, as in the moderate head injury, it was more. Agitation post head injury is very poorly defined, right? Post-traumatic agitation, post-traumatic delirium. So they have been explained under this broad heading, and sometimes as emotional and behavioral discontrol. The population in our study was more following acute recovery phase, wherein patient was out of delirium. Probably thus the rate of aggression and agitation might be less when compared to the traditional literature review. Annoyance usually may manifest as irritability, right? So Conning et al. Actually had reported decreased need for disturbed sleep, right? And that sleep depth itself may cause frustration, irritability, noise intolerance, right? Coupled with all these things can contribute to irritability. Post-traumatic aggression is reactive, easily provoked in nature, explosive. They occur sudden without any build-up. They are unplanned, and there is no clear objective behind that aggression. So these are like this. It has been reported by Davis et al. In our study, we could not get any delusions or hallucinations. Traditionally, like the psychotic symptoms have been reported like generally after a long period of gap from head injury, right? So usually 3 to 4 years down the line after head injury, and especially in temporal lobe involvement, temporoparietal. So borderline bipolar affective disorder is relatively uncommon post head injury. The irritability is more than classical euphoria or elation. Disinhibition component is more. So in our sample, only one patient qualified for manic-like presentation. Cognitive domain, patients with traumatic brain injury tend to have a difficulty in attention, concentration, organizing new information processing, speed, in encoding and its retrieval, right? So, and this basic functioning usually improves within 1 to 3 months in mild head injury cases, and in moderate head injury cases, usually it takes time, 6 months, 1 year, like that, right? In our study, the ACE scores showed that the cognitive domain involvement were more in moderate head injury when compared to mild head injury. The mean score of attention, visuospatial domains of cognition was statistically significant and lower in moderate head injury than the mild head injury group, showcasing that the neuronal injury is more in moderate injury. And the median score of memory and language was lower in moderate head injury group, reaching statistical significance in memory. In our study, almost 46% subjects had involvement of frontal and temporal lobe. That is why we also had a look at whether there is any correlation in neuropsychiatric symptoms. It is very difficult to comment on cognitive domains when lobes were taken into consideration, like especially frontal and temporal lobe when we couldn't get any statistical significance. Perhaps that is because in majority of the cases, it is attention and concentration that were predominantly involved. So it is very difficult to engage them into as such detailed neurocognitive assessment. So the conclusion is that the common neuropsychiatric symptoms on NPIC, that is the neuropsychiatric inventory clinician, were anxiety, sleep disturbance, appetite and eating disturbances, irritability, agitation, dysphoria, and aggression. The severity of neuropsychiatric and cognitive symptoms were directly proportional to the severity of head injury. Neuropsychiatric inventory covers a wider range of neuropsychiatric symptoms than other tools and minimizes administration time. It also gives perspective not only from a clinician point of view, from caregiver point of view as well, from the patient point of view as well. So this may help further in consultation liaison services, patient care, counseling of caregivers, and planning follow-up, leading to better long-term psychosocial outcomes, social reintegration, and higher quality of life for persons with traumatic brain injury and their families. During the immediate post-traumatic brain injury period, there is less scope for detailed cognitive assessments. So the limitation is small sample size, but the strength is that we had a detailed and robust exclusion criteria. So the time frame was a 6 months duration. That is probably one of the limitation. Convenient sampling. So we was the thing. In HADS scale, few questions like patients, they were not able to understand properly. Like say, for example, I get sort of a frightened feeling like butterflies in the stomach, right? Or something awful is about to happen. So these sentences had to be translated sometimes into local languages, right? And especially in while doing Edenbrook examination under retrograde memory, few subjects were not able to answer like name of the actor who was a hero in the film Mera Naam Joker. Like if the person has not seen the film, then how will he tell the name of the actor? So that is one tricky part. And similarly, in a Kannada version, there was they had asked who is the name of the actor in a film like Bangarada Manushya, right? So under the language domain, few subjects could not answer giraffe, and rather would tell it is like this animal looks like a camel. So this can happen especially in people who have not seen giraffe, right? So or people did not have the luxury to go to a zoo, perhaps, right? Also, few would answer like this tabla. Also, some people would say it is a more like a drum. So these examples illustrate the need for cultural adaptations and further revisions required in these kind of assessment tools. Thus, in some of the items of clinical interview and scales, we had to translate into local language while administrating, and this could affect the symptom findings. Although pretty sure it wouldn't have in our case, because but still for nitpicking sake, definitely it can happen because the patients belong to various language groups and education status. So there is nil conflict of interest. There are more references, but still put right this. So thank you for listening, and thank you for allowing me this opportunity to present my research findings. I wanted to present long back and I never did it. So, but this I got a good opportunity to present. Thank you.
Thank you. Any questions for Dr. Neeraj?
La pantalla. Bueno, primeramente agradecer a los organizadores de este evento importante. Vamos a compartir un poco de la experiencia que tenemos con los casos de neuropsicosis acá en Perú, en el Instituto Nacional de Ciencias Neurológicas, en este caso asociados a neuralgia de trigémino. Sabemos que la neuralgia de trigémino obviamente viene por una lesión de este nervio craneal, nervio trigémino. Puede ser una lesión propia del nervio intraxial o, lo más frecuente, por una lesión extraxial o una lesión externa, ¿no? Que puede afectar a varias de sus ramas. El dolor característico, como sabemos, de este tipo de neuralgia es ese tipo de dolor intenso, ¿no? Agudo, o corriente eléctrica, como lo describe la mayoría de los pacientes, muy limitante, que genera gran deterioro de la calidad de vida, ¿no? Los pacientes dejan de hacer sus actividades, las más básicas incluso, no les dejan ni comer, ni cepillarse los dientes. Y obviamente este estrés les va a generar también una gran carga de ansiedad, de depresión, que también hay que darle un mejor enfoque. Aproximadamente al año 4 a 29 personas sufren de este problema, ¿no? Cada 100.000 habitantes. Hay una ligera predominancia en mujeres, de 3 a 2 respecto a los varones. Y del total de neuralgias de trigémino, aproximadamente el 15% son neuralgias secundarias, ¿no? Como vamos a comentar más adelante. Esta es una clasificación donde se muestra más o menos los porcentajes de los diferentes tipos de neuralgia. El 10% son idiopáticas, cual no se demuestra una causa del dolor. El 75% son neuralgias clásicas, que conocemos la mayoría, las que hemos visto la mayoría de los casos, en los cuales vemos una presión, una injuria vascular, ya sea arterial o venosa, hacia el nervio trigémino, lo que genera pues las descargas de dolor, ¿no? Y finalmente las causas secundarias, que aproximadamente representan el 15% de todas las neuralgias, ¿no? Y dentro de estos, pues los más comunes son los tumores, ¿no? Del ángulo submucoso, meningiomas, schwannomas, quistes epidermoides, de los más comunes. También se han descrito malformaciones arteriovenosas, la esclerosis múltiple también, se han descrito casos muy raros como metástasis, granulomas, etcétera, ¿no? Aún no se considera en ninguna de las revisiones que hemos hecho, pues, a los quistes de neuropsicosis como causa de neuralgia secundaria, ¿no? A pesar que ya hay algunos casos reportados. Nada más para recordar, la neuralgia clásica, como habíamos comentado, es una neuralgia de las más comunes en las cuales se observa una compresión vascular, arterial generalmente, o venosa también puede ser, hacia el nervio trigémino, que le va a provocar algunos cambios estructurales ya en el nervio, ¿no? Ya se observa incluso en la resonancia cierta distorsión, cierta atrofia en la zona de compresión, ¿no? Los cambios estructurales hacen que el nervio sea más excitable, ¿no? O sea, con estímulos inocuos generan esas descargas que provocan ese dolor muy, muy intenso en los pacientes. En cuanto a la neuralgia secundaria, no hay suficiente evidencia como para tratar de explicar la fisiopatología, ¿no? Del dolor. Probablemente sea multifactorial. Tenemos muchos pacientes con angiomas del seno cavernoso, angiomas pedoclivales gigantes, pacientes con quistes, tumores epididimoides también gigantes, punto cerebeloso, schwannomas, y solo aproximadamente el 10% de los pacientes cursan con neuralgia. El resto de los pacientes, a pesar de tener incluso infiltrado o gran compresión del nervio trigémino, no generan dolor. No tenemos hasta ahora, digamos, una explicación clara de por qué el dolor. Probablemente también esté asociado al efecto de masa, ¿no? Que hace estos tumores, ya sea desplazando tal vez el nervio hacia una masa arterial o de repente una rama arterial hacia el nervio, ¿no? Más o menos ya sería como una neuralgia clásica, pero aún no hay suficiente evidencia como para sacar algo concluyente. Cuanto a la neuropsicosis, sabemos que es de la infección del sistema nervioso central más común, causada por una larva de la Taenia azul. Y bueno, es una enfermedad, es un problema de salud pública en muchos países de Latinoamérica, África, Asia. Hay millones de personas que sufren de esta enfermedad anualmente y más o menos 50.000 personas por año mueren secundarias a esta enfermedad, ¿no? De ahí la importancia de conocer un poco más sobre las alternativas de tratamiento en algunos pacientes. Hay países donde no se conocían, no se reportaban casos, ¿no? Pero debido a la gran migración, actualmente a la globalización que existe, pues ya se han reportado casos de neurosis, circosis en países, en lugares donde no se conocía. Esta es un mapa de la incidencia mundial, como vemos ahí, América Latina, Perú, Bolivia, Brasil, Centroamérica, países de África, de Asia, tienen todavía alta incidencia de esta enfermedad, ¿no? Como comentaba, de ahí la importancia de conocer un poco más sobre algunas alternativas de tratamiento en estos casos. Obviamente, un paciente con quistes con infección en el sistema nervioso central, encefálico o medular, pues sí les genera mucha morbilidad neurológica, también gran mortalidad. En cuanto a la presentación clínica, no hay una presentación clínica típica de neuropsicosis, ¿no? Va a depender mucho de la localización. Nosotros a veces comentamos que se parece mucho a la tuberculosis, ¿no? Que también te puede dar cualquier tipo de cuadro neurológico, ¿no? Es igual a neuropsicosis. Pero digamos, de las causas de consulta, pues la mayoría consulta por crisis epilépticas de todo tipo también, focales, tónico-clínicas avanzadas, las cefaleas y bueno, la hipertensión intracraneal, ¿no? Ya sea por quistes gigantes, múltiples quistes, por hidrocefalia, ¿no? En estos casos la hidrocefalia también es multifactorial, ¿no? Donde se afecta no solo la producción, la circulación, sino también la absorción de las velocidades aracnoideas, ¿no? Todos estos factores contribuyen de alguna forma a que el paciente desarrolle hidrocefalia, ¿no? Entonces son las formas más frecuentemente los pacientes consultan. Y de la clasificación de la neurocisticercosis, pues tenemos las que son intraparenquimales, las que afectan directamente obviamente, al parénquima encefálico, ya sea eh, medular o encefálico, como comentaba, y los extraparenquimales, ¿no? Y estos a su vez se dividen en las ventriculares y las subaracnoideas. Subaracnoideas también que le llaman la racemosa, ¿no? Obviamente estas formas de neurocisticercosis generan mucha morbilidad neurológica y también mucha mortalidad. Obviamente no se conoce actualmente completamente la fisiopatología de la lesión cerebral, vascular, ¿no? Tenemos pacientes con pues, poca cantidad de quistes que tienen una evolución tórpida, con gran movilidad, pero también tenemos pacientes con gran cantidad de quistes subaracnoideos que toleran muy bien, digamos, toda esa infestación. Entonces, aún no se conoce el por qué algunos pacientes hacen formas más severas y algunos, a pesar de que tienen gran infestación, pues toleran mejor esta infestación, ¿no? Tampoco se sabe por qué, cuál es el mecanismo por el cual la membrana del quiste se va replicando en el espacio subaracnoideo, ¿no? Sabemos que ya no tiene escoles, nada más son como pequeñas bolsitas de agua, entonces tampoco se conoce exactamente cuál es el mecanismo. Hemos intentado, estamos tratando de replicar este fenómeno. Estamos haciendo algunos trabajos en conejos, en cerdos, para tratar de replicar el mecanismo por el cual estas membranas, estos quistes, se logran replicarse en nivel de esos organismos. Todavía eso está en proceso, ¿no?, de investigación. Para el diagnóstico, obviamente la clínica, la epidemiología, las imágenes, la resonancia magnética, la secuencia fiesta, que conocemos que ya está descrito, que tiene más sensibilidad, especificidad para detectar los quistes, usamos también. Y aparte de eso tenemos un diagnóstico serológico, ¿no?, que también es parte de los criterios. Ya en 1989 SAM introdujo este criterio, ¿no?, este método diagnóstico que tiene alta sensibilidad y especificidad, ¿no? Este método pues explora anticuerpos, ¿no?, para antígenos de las membranas. Obviamente, mientras más parásitos, más quistes haya, la posibilidad va a ser mayor, ¿no? Y en teoría se describe que basta que haya un solo quiste viable a nivel cefálico cerebral, la prueba de Western ya sale positivo por lo menos una o dos bandas. Vamos a comentar este primer caso, una persona mayor de 78 años, mujer, que consulta con la clínica típica de la neuralgia de trigémino. En este caso, el lado izquierdo, un dolor muy intenso que no le impide incluso ya ingerir sus alimentos, ¿no? Entonces, se ha manejado inicialmente con antiinflamatorios, con carbamazepina, que es el medicamento que mejor ayuda a aliviar o controlar el dolor. Y bueno, al ver que no se controla el dolor y viendo las imágenes de la resonancia, pues piden nuestra evaluación para posibilidad de cirugía, ¿no? Aparte de esa semiología de Gemini, del lado izquierdo, pues no se encontró ningún otro hallazgo neurológico, ¿no? Y lo importante acá en la resonancia, en la secuencia fiesta, como vemos, los cortes axiales, vemos como el nervio trigémino está un poco lateralizado, ¿no?, distendido, medial y lateral hacia el nervio. Vemos dos lesiones quísticas, ¿no?, todas en las flechas amarillas. Y en FLAIR vemos esa hiperintensidad típica los procesos inflamatorios perilesionales, ¿no? Y en esta secuencia ante uno con gadolíneo vemos además, apareciendo en la imagen, una pequeña probable asa arterial que está en contacto con el nervio trigémino, ¿no? Es importante también revisar bien, en este caso, la resonancia para poder planificar eso. En este caso se hizo un abordaje de retrosigmoideo estándar, 2002 centímetros de peritonía, Exploramos hacia las cisternas, vemos estas cisternas medio amarillentas, típicas de las ranoiditis secundarias en neurosis. Luego de la apertura de la noides, pues ya se van exteriorizando los quistes. Y un dato importante que hemos observado durante estos años que manejamos pacientes con esta patología es que vemos que los quistes no están adheridos al parénquima o arterias o venas, están libres como flotando en el espacio subaracnoideo. Esto hace que su resección sea relativamente sencilla, ¿no? Muchas veces con irrigación, con solución salina, con pequeña tracción, con la aspiración, pueden salir completamente en racimos como vemos aquí, ¿no? Pequeñas tracciones, al final sale todo el racimo, todo el bloque de quistes, ¿no? De la primera etapa de la cirugía, como habíamos visto en la resonancia, hacia la base, a la emergencia del nervio trigémino de la protuberancia, se veía una masa arterial que se pudo observar durante la cirugía. Obviamente aprovechamos para disecar, liberar, separar esta asa arterial, una rama de la arteria cerebrosa inferior, y colocar finalmente un teflón entre la arteria y el nervio. Y esta es la vista final donde el nervio, desde su emergencia de la protuberancia, todo su trayecto ya no tiene ningún elemento externo que pueda estar irritado. En cuanto al resultado, la paciente pues, se alivió del dolor después de la cirugía, no tuvimos complicaciones en el preparatorio, en el postoperatorio, y en la resonancia de control a los 2 meses pues se puede evidenciar que esas lesiones quísticas laterales y mediales a la nervio pues ya no están, ¿no? Se ha logrado resecar, se ve el fragmento de teflón ahí, separando el asa arterial que habíamos visto, ¿no? Entonces, el paciente se encuentra con un ranking modificado de 0 y libre de dolor, ¿no? Entonces, el segundo caso, un paciente más joven, 25 años, mujer también, que también se consultó por un dolor neurálgico en el lado izquierdo, igual muy intenso, tipo corriente eléctrica, que ya le impedía hacer sus actividades básicas, ¿no? Como habíamos comentado. Y durante el examen neurológico, pues no se encontró ningún otro hallazgo semiológico. Y bueno, con la resonancia también nos piden la evaluación, ¿no? Es un caso un poco similar al anterior, pero en este caso vemos que igual el nervio trigémino está distendido, lateralizado, elongado, y los quistes o las lesiones quísticas están más mediales, ¿no? Mediales. Incluso acá se ve netamente anterior a la protuberancia, incluso desplazando vacilar hacia la protuberancia, ¿no? Entonces, analizando acá la anatomía del senos paranasales del paciente y viendo un clivus delgado del tercio medio, pues decidimos, en este caso, hacer un abordaje transclival, ¿no? El tercio medio. Este es el video de la cirugía, ¿no? Obviamente, antes de esto hemos preparado ya un colgajo nasocetal estándar típico, con su colgajo reverso para la protección del cartílago septal. Hemos drilado el tercio medio del clivus, más o menos una ventana de 1 centímetro y medio, y luego de la apertura dural ya procedemos pues a abrir la aracnoide, ¿no? Como se ve ahí, es una aracnoide grisácea, un poco gruesa, incluso un poco difícil de romper, de abrir, ¿no? Con esta unidad que usamos, y ahí ya podemos ver incluso ya esa coloración amarillenta, grisácea que son los quistes, ¿no? Seguimos disecando, tratando de liberar los quistes de las aracnoides, de aperturar o hacer una mayor ventana para poder resecar los quistes, ¿no? Entonces, como comentaba, muchas veces la irrigación de solución salina y con un catéter fino, muchas veces los quistes terminan de exteriorizarse solos, ¿no? Sin mucho esfuerzo. No, aquí, bueno, por lo menos nos ayuda un poco a poder visualizar mejor el quiste, ¿no? Y con una aspiración muy ligera logramos ya exteriorizar en parte los quistes, ¿no? Igual irrigamos más, ver si con eso era suficiente, pero en este caso pues no se logró exteriorizar. Así es que utilizamos una micropinza con una tracción muy ligera. Esperamos incluso que el mismo latido del encefálico, del cerebral, vaya exteriorizando poco a poco los quistes, ¿no? Como ahí se nota esa pulsación que hay que va expulsando los quistes con una mínima tracción. Hacemos movimientos hacia arriba, hacia abajo, laterales, para poder ir exteriorizando los quistes, ¿no? En este caso, pues no hay temor de que los quistes se rompan, no está demostrado alguna reacción local, vascular, parenquimal por el contenido de los quistes, ¿no? A diferencia de repente de otras neuroinfecciones como los quistes diabéticos, ¿no? En este caso, pues nunca hemos visto alguna reacción local ni sistémica por el contenido de los quistes, así es que manipulamos los quistes digamos, con mayor confianza, ¿no? Sí, vamos traccionando ligeramente, vamos viendo cómo van emergiendo las vesículas, los quistes, mm, se rompen, ¿no? Sí, pero realmente sin ningún problema secundario. Pues ahí ya estamos terminando de sacar los últimos fragmentos de las membranas, ¿no? Y finalmente retiramos los últimos fragmentitos de las membranas de los. Como ven, ahí no hay nada de sangrado, es un campo quirúrgico limpio, sin sangrado, ¿no? Sin sangrado completamente. Luego de extraer, revisamos el ángulo punto cerebeloso, ahí vemos todas las estructuras vasculares, el 7, el 8, los nervios bajos, esa es la parte inferior, y libre de quistes y esa coloración amarillenta típica de la aracnoiditis, ¿no? Propia de las cercosis. Irrigamos con un poco más de solución para ver si se exterioriza, si se exponen algunos quistes más. Volvemos a revisar y vemos que ya no hay lesiones quísticas, ¿no? En el ángulo cerebeloso. Entonces vemos acá al lado izquierdo la arteria basilar y vemos ahí el nervio trigémino con el televidero. Reconstruimos con su dura, un gasquet óseo y obviamente el colgajo nosocomial para sellar nuestro abdomen. El resultado en este caso, pues podemos ver, esta es la tomografía postoperatoria inmediata, donde se ve un pequeño neuroencéfalo sin mayores hallazgos, y la resonancia a los 2 meses, ¿no? En la parte inferior, donde se evidencia ya la ausencia de quiste, ¿no? O sea, la arteria basilar, incluso ya un poco distante a la protuberancia, y la ausencia de quistes y el nervio trigémino ya en su posición anatómica casi normal comparado con esta imagen donde se veía elongado lateralizado. Igual la paciente terminó finalmente libre de dolor, pasó a la unidad de neuropsicosis con los colegas de neuroinfectología para el tratamiento antiparasitario correspondiente, ¿no? Bueno, esos son los casos de pacientes con neuralgia asociados a psicosis, ¿no? Como comentaba, todavía tenemos muchos pacientes con todo tipo de cuadro clínico, ¿no? En este caso, nada más para comentarles, paciente con quistes de cercos en la cisura intraesférica anterior. En este caso, hicimos un abordaje transmuscular transcorpo calloso para resecar los quistes. Y aquí en la imagen de intraoperatorias, como vemos ya como ese complejo comunicante anterior está libre, ¿no? De quistes. La cirugía también sin complicaciones y con una mejoría neurológica del paciente. Este es otro trabajo muy interesante donde utilizamos la cirugía estereotáctica para resecar quistes del cuarto ventrículo, ¿no? Esta cirugía es de mínima invasión con un paciente despierto, con ligera sedación, con un trépano occipital, con las coordenadas del marco de estereotaxia. Llegamos directamente al cuarto ventrículo para una pequeña aspiración, resecar las membranas y los quistes. No tuvimos complicaciones severas en ninguno de los pacientes y se pudo resolver, digamos, el problema del cuarto ventrículo, ¿no? Es una nueva alternativa para estos casos. Normalmente uno hace un abordaje suboccipital, transtelovelar, para llegar hasta el cuarto ventrículo y manipular directamente, obviamente con todos los riesgos que se implican. Hemos tenido buenos resultados en estos casos. Y este es otro caso también reportado y publicado, un paciente con una gran cantidad de quistes de fibrosis, cercosis, cisternas basales, ¿no? Y llegó con gran compromiso neurológico en la paciente. Entonces, en este caso también decidimos hacer un abordaje endoscópico basal extendido. Se logró la resección de gran cantidad de quistes, una mejoría neurológica importante en la paciente. Y esta es la resonancia después de 2 años de tratamiento, ¿no? Junto con los colegas de la unidad de cisticercosis y de neuroinfectología. Entonces, vemos que prácticamente ya no hay quistes en la paciente. Actualmente está con un ranking modificado de 0. Bien, como conclusiones, pues, para comentar, la neurocisticercosis, como hemos visto, es un problema de salud pública en muchos países, de Latinoamérica, Asia, África. Comentaba, es importante conocer de repente estas nuevas alternativas de tratamiento neuroquirúrgico de mínima invasión. ¿Por qué? Porque muchos pacientes necesitan más de un procedimiento, ¿no? A veces necesitan una exploración endoscópica, derivaciones peritoneales, tienen quistes en sistemas basales, celares, supercelares, hemos visto anteriores, cilianos, etc. Entonces, el hecho de que un paciente se someta a varios procedimientos obviamente implica mayor riesgo de complicaciones. Entonces, pues, procedimientos mínimamente invasivos nosotros nos han servido para poder hacer más de un procedimiento con mínimo trauma para los pacientes, ¿no? El hecho de que sabemos que los quistes están libres en el espacio subaracnoideo sin estar adheridos a estructuras vasculares o al parénquima, pues nos da una gran ventaja para poder hacer este tipo de abordajes mínimamente invasivos. Y obviamente el tratamiento es multidisciplinario, ¿no? Con los colegas de la unidad de cisticercosis, de la unidad de neuroinfectología, ellos al final, luego de la cirugía, luego de que se extrae la mayor cantidad de quistes, ellos inician el tratamiento antiparasitario, ¿no? Obviamente, mientras menos quistes hayan, el riesgo de una reacción inflamatoria inmunológica mayor que pueda generar algún problema neurológico al paciente ya es menor, ¿no? Entonces, por eso es que un paciente antes de recibir un tratamiento antiparasitario, si tiene gran cantidad de quistes, pues se somete a cirugía y posteriormente ya va a pasar a la unidad para que reciba el tratamiento antiparasitario. Muchas gracias por la invitación. Los invitamos siempre a conocer nuestra maravilla del mundo, Machu Picchu. Esta es una foto del hospital donde trabajamos, en el Instituto Nacional de Ciencias Neurológicas en Lima, Perú. Muchas gracias por la invitación.
Very good morning to all of you. Let me introduce myself. I am Dr. Gitanjali Sharma, Professor in the Department of Physiology, Pandit B.D. Sharma, University of Health Sciences, Rohtak. So my topic of presentation is brainstem auditory evoked potential in iron deficient patients in response to treatment. Next. Introduction. Anemia is a major health problem affecting 1.6 billion people in both developing and developed countries, with serious consequences like increased risk of maternal and childhood mortality. According to WHO, iron deficiency anemia resulted in 273,000 deaths in 2004, with 90% of deaths occurring in low and middle income countries. Auditory dysfunction is an important consequence of iron deficiency anemia. It has a major role in myelin formation, besides its involvement in the synthesis and function of various neurotransmitters like serotonin, dopamine, and catecholamines. In iron deficiency anemia, a subclinical involvement of auditory pathway in the brainstem occurs, which is indicated by increased absolute and interpeak latencies and Bera waves. Brainstem auditory evoked potential are the potentials recorded from the ear and the scalp in response to a brief auditory stimulation to assess the conduction through the auditory pathway up to the midbrain. It comprises of 5 or more waves within 10 milliseconds of the stimulus. It is described in terms of duration and onset of response. Now the methods. The present prospective randomized study was conducted in the Department of Physiology in collaboration with the Department of Medicine at Pandit B.D. Sharma, PGIMS, Rohtak. Ethical clearance was taken from the ethical committee before the start of the research activity. A written consent was taken from all the patients enrolled in the study after explaining the method of the study in their own language. The study was planned to find out the response to iron replacement therapy and the correlation between the hemoglobin and an iron profile and Bera parameters both pre and post treatment. The subjects were divided into 2 groups. Group 1, 13 newly diagnosed cases of iron deficiency anemia of either sex of age group 18 to 55 years before and after 3 months of iron therapy. Group 2, 30 age and sex match control. Methods. The Bera recording. Subjects were put at ease and made to lie down, relaxed on a couch in a quiet room with low levels of electroacoustic interference. During mono-oral testing, it was important to mask contralateral ear to avoid recording a crossover response from inadvertent stimulation. Both the ears were tested individually using shielded headphones. 2 reference electrodes were attached to left and right mastoid, designated as A1 and A2 respectively. 1 active electrode was attached on the vertex labeled as CZ and 1 as ground electrode to forehead, termed as FZ. All the electrodes were plugged to a junction box and skinned to electrode impedance and has monitored and kept below 5K ohms. Absolute peak latencies of wave 1, 2, 3, 4 and 5 together with interpeak latencies of 1 and 3, 1 and 5, 3 and 5 were recorded. Now the results. Bera latencies of all absolute and interpeak waves of both the ears, they are decreased in response to iron replacement therapy after 3 months. Student pair t-test was used for statistical analysis. Statistical significant improvement was observed in wave 1 of left ear after 3 months of iron replacement therapy in anemic patients. No statistical significant differences were observed for interpeak latencies of both the ears in pre-treatment and post-treatment cases. So these are the recordings, pre-treatment and post-treatment. That before pre-treatment, the interpeak latencies of wave 2, 3, 4 and 5, they were increased, and after the treatment, the latencies were decreased. Now the discussion. In the current study, there was a prolongation of all absolute and interpeak latencies of both ears in iron deficient anemic patients. Our findings are consistent with those of Shankar et al. And Kankeria et al., Kuraki et al., Algurin and Khalifa. also observed the similar findings. There were no differences in amplitude. In the present study, we have incorporated the effect of iron replacement therapy to study the changes in BERA latencies in such patients. In the current study, statistical significant difference was observed in wave 1 of left ear in between cases and control, and the p-value is less than 0.01. Statistical significant improvement was observed in wave 1 of the left ear after 3 months of iron replacement therapy in anemic patients. The prolonged BERA latencies in iron deficient anemic patients were reversible to a greater extent with iron replacement therapy. The findings in the present study of prolonged latencies and interpeak latencies in all the waves in patient differed than in control and denote the generalized affection of ascending auditory pathways located in the brainstem, that is the cochlear nuclei, superior olivary complex, and in the midbrain, that is the lateral lemniscus and inferior colliculus. These effects could be attributed to the ischemic and thrombotic events associated with iron deficiency, as iron deficiency causes thrombocytosis, hypercoagulable state, and tissue hypoxia. Hearing abnormalities caused by iron deficiency anemia are best demonstrated by recording brainstem auditory evoked potentials. The severity of CNS dysfunction depends upon duration and degree of iron deficiency. Hence, electrophysiological and clinical improvement is seen in such patients after iron replacement therapy. Conclusion: the electrophysiological studies of BERA provides an objective method for monitoring the function of CNS, especially the auditory function, in iron deficiency anemia patients before and after iron replacement therapy. This neurophysiological parameter permits quantization of the effects of iron deficiency anemia on the auditory pathway and the extent and the rate of response to iron replacement therapy. Thus, we can conclude that brainstem auditory evoked potential is a useful, non-invasive tool for early detection of subclinical auditory dysfunction and in follow-up of patients with appropriate dose and duration of iron replacement therapy. So the acknowledgements, I'm very thankful to lab technician Mr. Satish Chawla. There's no funding, no conflicts, and ethical approval has already been taken by the ethical institution ethical committee. So these were the references. Thank you very much.